When you think about incision and drainage, deroofing and excision, there are lots of different tools that you can use to do any of those things. Okay. So, one thing that I hear very commonly is patients coming into offices saying, do you do CO2 laser excisions? Do you do this excision? What do you use to do the excision? So let me take you back to those 3 procedures. The most important thing is the principle associated with each procedure. For the deroofing, the opening it up, the scraping it out, removing all of that tissue. For the excision, getting around the root of everything to the best that you can and cutting out. Whatever tool you use, despite what people might tell you, doesn't really matter. And the reason I bring this up is as follows. A lot of insurance does not cover CO2 laser. Okay? And I hear a lot from patients, will my surgery be covered? Well, of course it's going to be covered. It shouldn't not be covered, okay? So if you aren't finding yourself in a situation where people are trying to charge, now when I say covered, I don't mean necessarily 100%. You may have a copay or you may have a high deductible, but if it's something that quote unquote HS surgery is not covered by insurance at all, that's not necessarily the space that I recommend that you be in, because it may just be that they're billing for the CO2 laser itself. The CO2 laser is a great tool. It can either work on the skin to ablate things, or it can be used for excisional surgery to cut things out. Well, guess what else I can use for excisional surgery? I can use a knife, a blade. I can use a special cautery machine on a cutting setting, which is my preferred amount. So CO2 laser is so expensive, and this misconception that you necessarily need CO2 laser has been something that's prevented people from getting access to care. Now, that being said, a lot of the dermatologists have it and love it and use it, and they may bill for it and it's covered by insurance, or they may not bill for it and they may charge an extra fee. But just know that what's more important is the technique that's being done, not necessarily what we're using to do the technique. Okay. All right. So we're talking about how it heals. And there's a couple different ways that we can go about the healing process. So we have the three types of surgeries or procedures. If you're left with a hole, how does it heal? So the first option is to close it up. Okay. So with everything I've taught you all so far, hopefully something good, what do you think can happen if you close it? It can get infected under the skin. Okay. Absolutely. Which is the fancy, dehiscence is a family tree, and reopen. Absolutely. What else? So we have infection, sorry, I just said it. Huh? Additional trauma to the skin. So yes, sometimes you can see, I have seen in some folks, more so with closures than not closures, that the stress of the surgery causes additional tissue or skin around the area to flare. And then the other is recurrence. And that's really the hardest part, is the recurrence, because when it recurs, you've now made this big cavity, which is a big open space, and your body wants to fill open space. So when it recurs along the incision line. Okay? The other thing I found when I used to close all of these was that they always drained. Why? Well, there was typically a big cavity. Sometimes I put in drains, sometimes I didn't. Or like we said, they get infected or they dehiss and so forth. But all of them seem to have some fluid that comes out. Okay? And that causes great angst to patients. Why is this fluid coming out? Why does it look this color? Is this normal? Is this not normal? So I found that it was almost easier to help educate them that there's less bad things that can happen with a wound if we leave it to heal it open by secondary intention. So over the last, I'd say 14 years, I have moved from closing everything to pretty much keeping everything open. If someone begs me to close something, I will. But we have to go through why is this a bad idea? And the bad idea for those of you who had surgery where it was primarily closed and it worked, that's great. Okay. But when you think about the disease and what the disease looks like, if you have uncontrolled inflammation in your body, and sometimes you don't really know, or if the stress of the surgery, the trauma of the surgery triggers more inflammation, it could make it so it doesn't heal well. So you're taking a gamble. And for some people, taking a gamble of closing it is okay. But other people, it depends on what their goals are and what they're looking for. It's better to keep it open. Yes.
For those people who get like a hole that leaks out that stairs, don't have inflammation, but it just won't close, what does that mean?
That is a loaded question. Typically, what it means is one of two things. So people who have HS heal really, really well. It's a myth that you have wound healing problems. So when we take a step back and we look at how wounds heal, there's different phases of wound healing that Brinley made a note to teach everybody about. But wounds can go from a phase called acute healing to like acute wound to a chronic wound. And when they become a chronic wound, all of the things going on in your body that's telling it to heal kind of dissipate. Okay. And your body says, this is chronic. We're just going to let it be. So there are things that we have to do to the wound to help get it back to that chronic state. So that's one explanation. The other thing that can happen is you can build up crap on it. And the crap is going to actually cause ridiculous pain. Like if someone has surgery and a week or two later they're in excruciating pain, say, send me a picture of your wound. You probably have some stuff that needs to come off. And literally the best way to get it off is to sit in the bathtub, warm bathtub, with a washcloth, and you do it under the water and literally just gently remove it. And actually things get nice and soft, so your gentle becomes a little more rigorous, much better than if it's done in the office when it's incredibly uncomfortable and painful for everyone, myself included, because I feel awful. And we're affected too as providers and physicians. But that's another reason that the wound doesn't heal. And then sometimes wounds, as I call it, just need a little extra love. So sometimes that red granulation tissue, typically when you have a hole, the granulation tissue fills from the bottom up and then the outside in, and that's when the scar starts depositing. Well, sometimes the edges of the granulation tissue can kind of roll over, and the body's giving it a signal that the wound's already healed when it's not. So that's when we have to remove some of that granulation tissue, which there's a couple different ways we can do to tell the wound again, no, you're not done healing. We need you to keep healing. Silver nitrate, you can use some medications that will help remove it and debride it. You can rub it, honestly, if it's not painful. And for some people, these things are painful. And pain is something that's, as much as pain is different for everybody in this room, pain is different even post-operatively for everyone. And it's really hard for me to tell how someone is going to respond to surgery. Pain, and we can talk about this a little further too if we have time, but pain is so multifactorial. There's all these different pathways in the brain and in the body. Lauren Ornstein is she's a physician, a dermatologist at Emory in Atlanta. She has studied this and she has some great talks on this. But there's multiple different pathways. We even know that psychology, like your psychologic state, how you respond to stress can drive your pain as well. So pain I've never been able to predict how people will respond after surgery. So for me, I set expectations. And then hopefully my goal is that you fit into the minimal pain. You're going to be uncomfortable after surgery, although I do have some people who actually have no pain, which I really don't understand. But typically what happens with HS pain is when you wake up from surgery, your HS pain is gone. I actually have a lot of fun asking patients, are you in pain? And they might say yes, or they might say, oh, I'm a little uncomfortable. I said, what about your HS pain? They said, oh, that's gone. I just feel uncomfortable, from the surgery. So it's really cool when that what's been described to me as that nagging, deep-seated, throbbing pain is no longer there immediately with doing surgery. You might have some sharp pain now from the sensitivities that have been going on with the nerves in the wounds, but that's a little different. So going back to the healing thing, primary intention healing, not a big fan of. And the other reason is this, and I'm getting really highly technical, but I pay a lot of, when we looked at the images of the slides, I pay a lot of close attention to the edges of the wound, what the edges of the wound look like, and I tend to destroy the edges of the wound a little bit. And what I mean by that is we know that there's microscopic disease there. So I really pay attention to make sure that I'm not leaving anything visible to the naked eye. That's number one, because then you're guaranteed to have a recurrence right there. But I also want to stimulate the body to put scar down in that area, because if we put scar down, there's less likely a chance of having more disease. So I'm kind of trying to create a barrier around that wound to protect it from anything kind of sliding back in, if that makes sense. And I hope that makes sense. So the way I actually learned this more from the dermatologists, who literally, we as surgeons, we're taught to close things and we're taught to cover things. So the whole thought of leaving a giant wound open is foreign to some of us. And the reality is they heal really, really well. And I remember going to one of my first HS meetings and seeing someone show a picture of an excision about this big. And I said, that healed up to that line? Really? And it did. So I started playing, I say that loosely, and trying it. And it worked, and it works really, really well. And I think the outcomes are greater, or better. As a field, we have moved more towards secondary intention healing. What are the pros? All those things that we talked about in terms of not having it fall apart, not infection, not having the tension. With the armpits, if you suture the armpit shut, they're this way for at least 3 weeks. Your shoulder can get frozen. You can't move. You can't move around. If you have small kids at home, what are you going to do? Whereas if we just do an excision and cut it out, you can move your arm here like this tomorrow. In fact, you can move your arm better after surgery probably than you could before, with all the scarring and the pain and the inflammation. So wounds want to heal, and most wounds will just heal if you keep it moist. Okay, so you may have heard of us taking gauze and putting some saline on it and changing it every day. So that's one way to do it, and they typically heal pretty well. I use a special, what's called a silver alginate, which is a special felt-like material. The reason I use that is it helps minimize the amount of bacteria that colonize in that area that can cause some crap to form that will prevent it from healing. The other thing is I can describe it to people like arts and crafts. You're going to take a piece of felt, you're going to lay it in the wound. And actually, I typically don't cut it like this, but this happens to be an example where we kind of cut it to lay it in. But it's foolproof. And that's what, if you say to a family member who's frightened, it's kindergarten level arts and crafts, they're like, oh, I got it. Put a piece of felt in the wound. It's all good. So one of the other things that we do is use Vaseline on the wounds. Okay, Vaseline, petrolatum jelly. We can use antibiotic ointment as well. The purpose of the antibiotic ointment is not to retard any bacteria from forming. It's to keep it moist. Going back to that theme, we know that wounds like to heal well when they're moist. This is all new information from the last 10 years. Correct. It used to be, and even, when I trained, it was wet to dry, is what we called it, wet to dry. And the whole idea was you put something wet in, it dries, and then when you pull it out, it's going to adhere to the skin or the underlying tissue, and it's going to rip out all the stuff underneath, which is bad stuff that needs to come off. And now we realize, no, that's not the case. But you can still get bacteria and other things that build up here. And let me show you see this little white stuff right here? So this is stuff I like people to pay attention to the edges and like gently rub it after about a week and try to get that off, because this is something that will prevent the wound from completely closing. I call it fibrinous debris, but yeah, for the most part. So the people like to use the antibacterial ointments because they think, oh, it's going to prevent me from getting infection. But if there's one thing I've learned from the dermatologist is that a lot of people, I think it's 30 or 40% of people in general have actually reaction to bacitracin and some of the others as well. So plus it's expensive. If you have a big wound, you're going to be buying tubes and tubes of antibiotic ointment when you can just use a big tub of Vaseline. Much, much easier. So I advise against it. And I think for the wound to heal, other than keeping it moist, the most important thing is going to be to clean it really well. And even when you clean it, you can over clean. Okay. The best way to clean it is mechanically. Take a washcloth, get in the shower, and clean it out and rub. You got it. Scrub it out and wipe it out. And it shouldn't hurt. And if once you get all the stuff, that stuff that needs to come off, it won't hurt anymore. It might ooze a little bit. It might bleed a little bit, but that's normal and that's okay. It'll stop.
It's the emotional trauma that you're afraid is going to happen as opposed to what that actually feels like.
Yeah. I have a really cool video I'm happy to show you all of one of my dear patients who, actually it's the one with the perineal area, but we did his armpit recently, and he came in the next day for some reason to see me. And I said, hey, let us do your wound care. This will be fun. So we did his wound care, and he gave me permission to video it. But you can see we're touching it, and he's got like no pain at all. But again, everybody's different. That's not true of everybody. So we want to set those expectations. And the way I talk about pain is that your HS pain will be gone. You're going to be uncomfortable. But what does pain mean? Okay. Is pain sharp pain? Is it electric pain? Is it throbbing pain? It's different for everybody. So what I tell people is our goal is to get your pain down to something where you're like, I had surgery. This is not comfortable, but I can manage it, as opposed to getting your pain down to zero. The only way to get your pain truly down to zero is to pretty much knock you out with narcotics. And we as physicians are a really tough situation right now because of the opioid epidemic, which nobody here caused, but we are very, very highly regulated with what we can write, what we can't write. Different types of physicians have different permissions as far as how long they can write things, and every state is actually very different. So I give people one prescription of narcotics. We alternate that with Tylenol and ibuprofen. Ice is amazing. Ice is absolutely amazing. It tricks your pain fibers down there to feeling the cold instead of feeling the pain. So typically, people only need one prescription of the narcotics. Occasionally, if we're talking about another prescription, we may look at some adjunctive things or stuff like that. Before surgery or after surgery? Yeah. 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 The treatment for the pain for HS is not chronic pain management. It's controlling the inflammation. The inflammation is causing the pain. So if we can figure out how to manage your inflammation with a combination of the medications, the surgery, and the lifestyle modification, that will get you in a much better place than us just masking the pain. And the reality is, for some people, you may still need to be on some chronic pain medication. So please don't think I'm saying that nobody should be on them. But follow me for a second. And if you're having that much pain and they're sending you to chronic pain management, you probably aren't getting the medical treatment that you need. Okay. And actually, that was one of the comments I wanted to make before. This is more in Dr. Daveluy's wheelhouse. We could just tag team this, Steve. So, and you're welcome to. So, biologics are great. Okay. People are absolutely scared of them, and there are some side effects. So, if you have a concern or a fear about it, it's really important that you talk to your dermatologist about what your fear is, what your concern is, so that you can weigh that against what the potential benefit of it is. But I can't, first of all, I always keep people on biologics for surgery. We never stop them. We finally have a study, the Sharps trial, which shows that there's no increase in complications or anything like that. We've been operating with biologics for other conditions, Crohn's disease, ulcerative colitis, for years and years and years. And those are big, high-risk operations. And the patients do well. The risk profile with hidradenitis surgery is much smaller. So it's okay and you want to stay on the biologics. That being said, I have a lot of people who come to me and they say, oh yeah, I stopped it. It didn't work. And you say, wait. So talk to me. What do you mean it didn't work? And they said, well, I was still getting flares. I still had HS. It didn't go away. But here's the funny thing, and this is an important statistic for you all to know. There's 2 FDA-approved drugs right now for HS. There are a number of they're biologics. There's a couple other ones that are used off-label for various different reasons. Or, for example, you might have like another autoimmune or another autoinflammatory disease that might respond well. But in both, and there's a couple more drugs coming in the pipeline. Thank you, UCB. When you look at the data, in 50% of patients with severe disease, there was a 50% reduction in symptoms. Okay? So, what does that mean clinically? It means that this is not a miracle drug. It will not make your HS go away. It might decrease your flares. It might decrease your pain. It might prevent the progression or minimize the progression of new disease, which is hard to study. Okay, so we don't know. The other thing we haven't talked about is that there's a lot of other things happening in the body beyond the impact that we see on the skin. Okay, so fatigue is a big one. A lot of folks have GI issues, belly issues, joint pain, another one we hear a lot of, and I have a lot of people, the biologics are actually helping with all of those systemic issues. Whereas the biologics, you may not necessarily see the benefit in your skin. You may be seeing the benefit throughout your entire body. So I highly recommend people stay on them if they can. I think that's our best approach. And I'm more of a fan of biologics more so than even the other modalities. Dr. Daveluy. Why don't you just come up here? Come on. We're like the dynamic duo.
That's right. Wonder Twin powers. Activate. Oh, awesome. Oh, yeah. Look at that. So they haven't done super rigorous studies in pregnant patients because no one ever does because they don't want any risk. But we have a lot of data from people who have gotten pregnant on biologics, and that kind of tells us what we can do. So generally, the ones that are available for HS are safe. The one adalimumab or Humira that's out right now blocks TNF-alpha. Like I said, lots of people have had no issues with it. Some people will stop it toward the end of the 3rd trimester because when right before pregnancy, mom gives a bunch of antibodies to the baby so that it comes out and is safe from all the infectious things that are out there. And it's an antibody, the biologic, Humira, all of them are. And so we think some could get passed to the baby, and it might not make the vaccines work as good because you have it there. Having said that, we also have data from COVID that you can get the COVID vaccine when you're on it, and it works perfectly well. It doesn't affect that at all, so it probably is totally fine. So some people will stop in the 3rd trimester so baby doesn't get any just in case. Some people will keep treating through, and then they'll just wait until 6 months to start the vaccines for the baby, just to be safe. But like I said, there's actually a lot of safety that it is okay, even in people who haven't done those things, but they're not super rigorous studies. It's more people who got pregnant, and then, you know, we follow them after. Same thing, the other one that's available right now is Cosentyx. And so that one, same thing. We have data that shows no problems with people who were pregnant taking it for whatever reason. What's really crazy is we also have data about how HS impacts your pregnancy. And HS increases your risk of having an abortion, a spontaneous abortion, like losing your baby. And so that's one of the big things we say is we need to control the HS to reduce these pregnancy risks that can come with that. So that's one of those really tough to manage things. Like we want to treat the disease, we want to be safe about it, and that's why it's so individualized. But it's a good conversation to have, and I'm so grateful to patients who are on the treatments, get pregnant, and then they do these registries so we can learn about it and see what happens. So breastfeeding is really interesting. We don't have a lot of good data on it, but these biologic medicines are injections because if you digest them, they don't do anything. And so we think a tiny bit could get into the breast milk, but then the baby will just digest it. So we don't have data for it, but at the same time, like scientifically, we know that it should be okay to do during breast, and there's been no problems with that.
And continuing on the theme of pregnancy, it's a myth that you have to have a C-section when you have HS in that area. Okay. And I hear that all time and time again from OBGYNs. My husband's an OBGYN. He actually knows what to do. But even so, please, there's no reason that people with HS can't have a vaginal birth. And if there's HS on the breast, they can still breastfeed. No issues there.
Like, again, it's different for everybody, right? So we have a group of people that go into remission, spontaneous remission, which we do see with a lot of other autoimmune conditions, but as we know, like this is autoimmune. And then other people like myself, like I just went off the fucking wall when I was pregnant. But the postpartum, holy shit. I feel like across the board, like it just go bananas.
So I think in HS, some people have a stronger hormonal influence than other people. Mm-hmm. And for as many patients as I've had who've said their HS has gotten worse with pregnancy, I have plenty who said they've gotten better during pregnancy. Yeah. So I think it's really comparing apples to oranges. And unfortunately, I don't think our society is in a space where we have enough information to really study that.
Right.
Like, if you could give someone who's pregnant who's like has HS, like if you could like prepare for the postpartum HS.
Well, they may not have it. That's the thing. So what we don't want people to think is that they shouldn't get pregnant and they shouldn't embrace, in the joy of having children. Yeah.
Yes.
Oh, hemorrhoids are middle age. It's great. It's fantastic. You don't know about that yet. You're too.
Yeah.
We can take care of your HS and your hemorrhoids.
One of the things I'll do if someone one of my HS patients becomes pregnant is I'll plan with them. So sort of doing some of those scheduling, like I want to see you. I know you never know exactly when baby's coming, but I want to see you in that postpartum period, like scheduling out those visits to be like, I want to see you during the third trimester. I want to see how things are going. Postpartum, let's make another, and like, go ahead, let's plan all these appointments now. And we can be flexible and move them if baby decides it's going to come at a different time. But just being ready, because that way you have the appointment so you can sort of deal with whatever happens. If it's doing great, you're like, awesome. If it does flare up, you've got some treatment options. And I always encourage breastfeeding because it's so good for the baby.